Dr. Rawan, تفضل, you can start.
Sure. Assalamu alaikum. My name is Zalma Ghamdi, cardiac surgery resident R2 from Prevalence Cardiac Center here in Riyadh. Inshallah, today I'll be talking about anatomy. I will start with the first lecture, the anatomy of the cardiac chambers and the conduction system. And the second lecture, inshallah, will be about the anatomy of the great vessels of the heart and the coronary arteries and coronary veins. So these are the objectives, the four cardiac chambers, the anatomy of the four valves, the conduction system, and finally the mediastinal nerves and its relation to the heart. So the heart is a three-sided pyramidal shape having the apex, the sternocostal surface, which is the anterior surface, the base, which is the posterior surface, and the diaphragm, which is the diaphragmatic, which is the inferior surface. It has two edges, the acute margin, which lies at the inferior aspect and described as a sharp angle between the sternocostal and diaphragmatic surface, the obtuse margin, which lies at the superior aspect, and it's much more diffuse. Anteriorly, it is covered by the sternum and the costal cartilage of the third, fourth, and fifth ribs. The right lung overlies the right surface of the heart and reaches to the midline. The left lung retracts from the midline in the area of the cardiac notch. Posteriorly, it lies on the esophagus and the tracheal bifurcation, and inferiorly, it lies on the diaphragmatic surface. The heart lies within the pericardium, which is attached to the walls of the great vessels and the diaphragm. It consists of two layers, the fibrous pericardium, which is made of tough connective tissue, and it's continuous with the central tendon of the diaphragm. The serous pericardium, which itself has two layers, the visceral and the parietal pericardium. The visceral pericardium is the inner layer that is in direct contact with the heart and extends several centimeters back into the walls of the great vessels. The parietal pericardium, which is the outer layer, which lines the inner surface of the fibrous pericardial sac. In between, there is a thin film of a lubricating fluid that lies within the pericardial cavity between the two serous layers, around 10 to 5 ml. We have two sinuses, the transverse sinus, which is the tunnel-shaped passage posterior to the aorta and pulmonary trunk and anterior to the superior vena cava. We have the oblique sinus, which is an inverted U-shaped reflection of the vena cava and the pulmonary vein. It lies behind the left atrium and in between the left and right pulmonary vein. It separates the base of the heart from the descending aorta and the esophagus. So we'll start with the right atrium. The right atrium has three basic components: the atrial appendage, the vestibule, and the venous component. Atrial appendage has a triangular shape with a wide junction to the venous component. The venous component is the superior vena cava, the inferior vena cava, and the coronary sinus. And the vestibule is the smooth wall atrial myocardium that insert into the leaflet of the tricuspid valve. Externally, the junction of the appendage and the venous component is identified by a prominent groove called the terminal groove or sulcus terminalis. This corresponds internally and forms a ridge which called the terminal crest. The most characteristic and constant feature of the right atrium is the pectinate muscle. These muscles originate as parallel fibers that course at the right angle from the terminal crest. The Eustachian valve, also known as the valve of the inferior vena cava, which is an embryological remnant of the inferior vena cava that during the fetal life helps to divert the oxygenated blood from the IVC toward the foramen ovale to escape the pulmonary circulation. This remnant usually regresses.
روان
Yeah.
صوتك بعيد.
كده أوضح؟
It's interrupted a little bit يعني. I'm not sure if it is me only, guys. Continue, Rowan, continue.
Okay. So as I was saying, the Eustachian valve, this remnant usually regress after birth and is
الصوت
considered
عندك طبعا في مشكلة.
مشكلة. كده أوضح؟ صوتي واضح ولا لسه؟
لسه بعيد الصوت.
Sir, are you wearing headphones or is it through the laptop?
لا, through the laptop. So it's still not clear?
I can hear it, but it's يعني شوية بعيد بس I can hear it. I don't know about others.
Looks the mic is covered by something.
No, it's not covered. It's I think this is the maximum. Shall I continue?
Yes, it's better now. تفضل.
Okay. So as I was saying, the Eustachian valve, this remnant usually regress after birth and is considered a benign finding in majority of cases. The Eustachian valve is also known as the valve of the coronary sinus, which may prevent the regurgitation of fluid into the coronary sinus during the contraction of the atrium. The fossa ovalis, which during the fetal development, the foramen ovale allows the blood to pass from the right to the left atrium, bypassing the non-functional fetal lung. A flap of tissue called the septum primum acts as a valve over the foramen ovale during that time. After birth, the introduction of air into the lung causes the pressure in the pulmonary circulatory system to drop. This change in the pressure pushes the septum primum against the atrial septum, closing the foramen and leaving this depression. The tricuspid valve consists of 3 leaflets: the anterior leaflet, which is the largest leaflet, the septal leaflet, and the posterior leaflet, which is the smallest leaflet. The leaflet join together over a 3 prominent zone of apposition. The peripheral end of these zones usually are described as the commissure. We have the anterior septal commissure, the anterior posterior, and the posterior septal commissure. In the tricuspid valve, there is no well-formed collagenous annulus. There are 3 papillary muscles that support the tricuspid valve. The anterior papillary muscle, which is the largest, that rise from the moderator band and support the anterior leaflet of the valve and the zone of opposition between the anterior and posterior leaflet. The medial papillary muscle that support the septal leaflet of the valve and the zone of opposition between the septal and anterior leaflet. And the posterior papillary muscle, which is the smallest, that supports the posterior leaflet of the valve and the zone of opposition between the posterior and septal leaflet. Like the right atrium, the left atrium has 3 basic components: the atrial appendage, the vestibule, and the venous compartment. The left atrial appendage is long and narrow. It has a different variation in size and shape, but all are generally a finger-like projection from the left atrium. It lies to the left of the mitral valve orifice. The vestibule is directly continuous with the smooth atrial wall of the pulmonary venous component and inserts directly into the posterior leaflet of the mitral valve. There is an important difference between the relationship of the appendage and the vestibule between the left and right atrium. In the right atrium, as I mentioned, the pectinate muscle within the atrial appendage extends around the parietal margin of the vestibule. In contrast, in the left atrium, here the pectinate muscle are located almost exclusively within the appendage. So the left atrium poses a large smooth wall body which represent the larger part of the atrial component. Also, unlike the right atrium, here the venous component of the left atrium, which is the forepulmonary vein, is considerably larger than the atrial appendage and has a narrow junction with the vestibule that is not marked by a terminal groove or terminal crest like the one in the right atrium. The competency of the mitral valve is maintained by several different components acting in harmony. We have the mitral valve leaflet, the mitral valve annulus, the papillary muscles, the chordae, and the left ventricle. The mitral valve consists of two leaflets with different appearance. You have the anterior and the posterior leaflet. The anterior and posterior leaflet are subdivided by clefts into scallops known as A1, A2, A3 in the anterior leaflet and P1, P2, P3 in the posterior leaflet. The anterior mitral leaflet takes approximately 2/3 of the cross-sectional area of the mitral valve orifice, and it's related to the LVOT via the aortomitral curtain. The posterior leaflet takes up to 1/3 of the cross-sectional area of the mitral valve orifice and is connected to the parietal part of the atrioventricular junction. The mitral annulus is a fibrous ring that is attached to the mitral valve orifice. It contracts and reduces the surface area during systole to help to provide complete closure of the leaflet. Unlike the tricuspid valve, the mitral valve leaflet are supported by a dense collagenous annulus. The annulus is a kidney shape with the anterior mitral annulus taking 1/3 of the circumference and the posterior mitral annulus taking 2/3 of the circumference. Two papillary muscles supports the mitral valve. The anterolateral papillary muscle, which has a single head and takes its blood supply from the left circumflex artery. The posteromedial papillary muscle, which has multiple heads and takes its blood supply from the right coronary artery. The chordae are a thin web-like fibrous structure, primarily responsible for the end-systolic position of the anterior and posterior leaflet. It arises from the papillary muscle. They are classified according to their site of insertion between the free margin and the base of the leaflet. So primary, which are inserted on the free margin of the leaflet and function to prevent prolapse of the leaflet. The secondary, which is inserted on the ventricular surface of the leaflet and relieve the valve of excess tension. And the basal or tertiary, which are limited to the posterior leaflet and connect the leaflet base and the mitral annulus to the papillary muscle. There are anatomical structures close to the annulus that are at risk during surgery. We have the left circumflex artery, which runs between the base of the left atrial appendage and the anterior commissure. 3 to 4 millimeter from the leaflet attachment, and then moves away from the rest of the posterior annulus. We have the coronary sinus, which is initially in a lateral position to the posterior leaflet, and then crosses the artery and become medial, closer to the posterior leaflet attachment, around 5 millimeters superior to the annulus. And we have the non-coronary and left coronary aortic cusp, which are in close relationship with the base of the anterior leaflet. Although slight variation exists, these cusps are around 6 to 10 millimeter away from the anterior mitral valve annulus. So this distance is represent a safety zone for the placement of suture in this area, provided that the needle is properly oriented toward the ventricle. The morphology of both the right and the left ventricle can be understood best by subdividing the ventricle into 3 anatomical components. We have the inlet portion, the apical trabecular portion, and the outlet portion. This classification is more helpful than the traditional division of the right ventricle into sinus and conus part. So the inlet portion of the right ventricle surrounds the tricuspid valve and its tension apparatus. The apical trabecular portion of the right ventricle extends out to the apex. And there, the wall of the ventricle is quite thin and at risk of to perforation by cardiac catheter and pacemaker electrode. And finally, the outer portion, which consists of the infundibulum, circumferential muscular structure that support the leaflet of the pulmonary valve. A distinguishing feature of the right ventricle is a prominent muscular shelf, which is the supraventricular crest. It separates the tricuspid and pulmonary valve. In reality, this muscular ridge is the posterior part of the subpulmonary muscular infundibulum that support the leaflet of the pulmonary valves. The pulmonary valve consists of 3 semilunar leaflet, the right cusp, the left cusp, and the anterior cusp. Because of the semilunar shape of the pulmonary valve leaflet, this valve doesn't have an annulus in the traditional sense of a ring-like attachment. Instead of a single annulus, 3 rings can be distinguished anatomically in relation to the pulmonary valve. We have superiorly, we have the sinotubular junction of the pulmonary trunk, which marks the liver of the commissure. We have the second ring exists at the ventriculo-arterial junction, and a third ring is the basal ring, which can be constructed by joining together the basal attachment of the 3 leaflet to the infundibular muscle. The left ventricle can be divided into 3 components as well: the inlet, the apical trabecular portion, and the outlet portion. The inlet portion limited by the mitral valve and its tension apparatus. The apical trabecular component is extending to the apex. Here the myocardium is thin and the trabeculation of the left ventricle is quite fine compared with the right ventricle. The outlet portion, which supports the aortic valve and consists of both muscular and fibrous portion. This is in contrast with the infundibulum of the right ventricle, which consists entirely of a muscular portion. So the aortic valve is a semilunar valve that is quite similar morphologically to the pulmonary valve. Likewise, it does not have a discrete annulus. Because of its central location, the aortic valve is related to each of the cardiac chambers and valves. So through knowledge of this relationship is essential to understanding the aortic valve pathology and many congenital cardiac malformation. So the aortic valve consists primarily of a right coronary cusp, a left coronary cusp, and none or the posterior coronary cusp. The leaflet are formed by a fibrous core and endothelial lining. The commissure are the point of contact between the leaflet on the aortic wall. So the aortic root connects the LVOT to the ascending aorta. It extends from the basal attachment of the aortic valve to the sinotubular junction. The function of the aortic root is to guide the unidirectional flow of large volume of blood with minimal resistance while maintaining a laminar flow and to optimize the coronary blood flow. It is deeply anchored within the base of the heart between the pulmonary root anteriorly and the mitral and the tricuspid valve posteriorly. So the competency of the aortic valve is maintained by several different components of the aortic root working together in harmony: the aortic valve leaflet, the sinuses of Valsalva, and the junctions. Behind each leaflet, the aortic wall bulges outward to form the sinuses of Valsalva. It extends from the sinotubular junction to the aortic annulus, which allows the aortic valve leaflet to fall back during systole, thereby enabling blood to pass unobstructed from the left ventricle to the aorta. There are 3 aortic sinuses, 1 anterior and 2 posterior. We have the left posterior coronary sinus, which gives rise to the left coronary artery. The anterior right coronary sinus, which gives rise to the right coronary artery, and the right posterior aortic sinus. Usually it gives rise to no vessels and is often known as the non-coronary sinus. The junctions, we have the sinotubular junction between the distal part of the sinus and proximal part of the ascending aorta. We have the ventriculo-arterial junction between the ventricular myocardium and the aortic sinus, and the basal ring, which is the joining of the inferior aspect of the valve leaflets. Structures that are at risk during aortic valve surgery. Number 1, we have the bundle of His, which is the most important structure. It is normally located at the junction between the membranous and ventricular septa in the subcommissural area between the non-coronary and the right coronary sinus. We have the membranous septum itself may be injured because of its fragility and the risk of tear following inappropriate suture placement. We have the thin proximal part of the aortic sinus, which is attached to the annulus. It's also at risk whenever very large bites are passed around the annulus rather than through it. The left main coronary artery is also a site of potential injury because of its proximity to the subcommissural area of the right and left sinuses. The cardiac conduction system consists of the SA node, the anterior, middle, and posterior intranodal tract in the right atrium, and the Bachmann bundle in the left atrium, the AV node, the bundle of His, the bundle branches, and the Purkinje fibers. SA node is an elliptical or horseshoe-shaped subepicardial structure that lies just lateral to the junction of the superior vena cava and the roof of the right atrium at the superior end of the terminal groove, which initiate the electrical activity of the heart. It's receive the blood supply from the sinoatrial nodal artery, which originate from the RCA in 55% of the patient, and from the left circ in 45% of the patient. It passes, the artery passes in front of the junction between the superior vena cava and the right atrium roof in 60% of the patient, behind the junction in 33% of the patient, and around the junction in 7% of the patient. After initiation of the electrical impulse from the SA node, the conduction of depolarization wave from the SA node to the AV node goes through 3 internodal tracts: the anterior, the middle, and the posterior tract in the right atrium, and the Bachmann bundle in the left atrium, which is a branch from the anterior internodal tract. This enables almost a simultaneous depolarization of both the right and the left atrium to maintain synchrony. The AV node lies within the triangle of Koch. The boundaries for the triangle of Koch are the tendon of Todaro, which is a fibrous structure formed by the junction of the Eustachian valve and the IVC of the Eustachian valve of the IVC and the Bayesian valve of the coronary sinus. The other boundary is the hinge of the septal leaflet of the tricuspid valve and the superior margin of the coronary sinus. So the AV node is located at the apex of this important anatomical area. It receives its blood supply from the AV nodal artery, which originates from the RCA in around 85 to 90% of the patient, with the remaining 10 to 15% originating from the left circ. The Kugel's artery, which is an anastomosis vessel between the proximal right coronary artery and the left circumflex artery, that also can provide a branch that runs through the base of the atrial septum, where it supplies a collateral circulation to the AV node. The bundle of His penetrate directly at the apex of the triangle of Koch before it continues to branch on the crest of the ventricular septum. There are 2 bundle branches: the left bundle branch, which divides into anterior and posterior fasciculi that runs subendocardially down the septal surface of the left ventricle to the apex. The right bundle branch, which runs on the right side of the ventricular septum toward the base of the medial papillary muscle of the tricuspid valve into the body of the septomarginal trabeculation, and it crosses the right ventricle cavity through the moderator band. The Purkinje fibers, which are specialized conducting fibers with a large number of mitochondria that are able to conduct cardiac action potential more quickly and efficiently than any other cells in the heart. It is located in the inner ventricular walls of the heart in the subendocardium. The Purkinje fibers allow the heart's conduction system to create a synchronized contraction of the ventricle and are therefore essential for maintaining a consistent heart rhythm. finally, the mediastinal nerves and its relation to the heart. The phoretic nerve, which is a mixed motor sensory nerve that originate from the C3, C4, and C5 spinal nerves in the neck. It is the only source of motor innervation to the diaphragm and therefore plays a crucial role in breathing. It also provides a sensory supply to the diaphragm, to the pericardium, to the mediastinal pleura, and to the peritoneum. It lies on the anterior surface of anterior scalene muscle and just posterior to the internal mammary artery at the thoracic inlet. So in this position, it is at risk to injury during the internal mammary artery harvesting. The right and left phrenic nerve have different course in the thorax, but as a general rule, they descend as lateral as possible while keeping in contact with the mediastinal pleura. Both travel anterior to the hilum on their respective side. So we have the right phrenic nerve descend in the thorax along the right side of the right brachiocephalic vein and the superior vena cava. It passes in front of the root of the right lung and runs along the right side of the pericardium, which separates the nerve from the right atrium. Then it descends on the right side of the inferior vena cava to the diaphragm. Its terminal branch passes through the caval opening in the diaphragm to supply the central part of the peritoneum. The left phrenic nerve descends in the thorax along the left side of the left subclavian artery. It crosses the left side of the aortic arch, passes in front of the root of the left lung and descend over the left surface of the pericardium, which separate the nerve from the left ventricle. On reaching the diaphragm, the terminal branch pierces the muscle and supply the central part of the peritoneum. The vagus nerve represents the main component of the parasympathetic nervous system to the heart. Among a number of different functions of the vagus nerve, in relation to the heart, it has a parasympathetic effect which regulates the heart rate, and a sensory effect which provide visceral sensation to the heart through the cardiac branches that arises in the thorax. These parasympathetic innervation to the sinoatrial and atrioventricular nodes of the heart stimulate a reduction in the resting heart rate. They are constantly active, producing a rhythm between 60 to 80 beats per minute. We have the right vagus nerve, which enters the thorax by crossing the first part of the subclavian artery and posterior to the innominate artery, then travels behind the primary right bronchus and esophagus to form the esophageal plexus with the left vagus nerve. The left vagus nerve enters the thorax by passing between the left common carotid and the left subclavian. Then it travels behind the primary left bronchus and into the esophagus to form the esophageal plexus. It exits the thorax along the esophageal hiatus. So finally, the nervous supply to the heart is autonomic, consisting of both sympathetic and a parasympathetic part. The sympathetic nervous system acts on the SA node, speeding up the depolarization rate and therefore increasing the heart rate. The parasympathetic system works in reverse in order to slow the heart rate down. So the heart itself has a natural pacemaker, which is the SA node. It does not need a nervous supply to function. If you cut all the nerves to the heart, it will continue to beat. In fact, it will beat faster than normal, since there is normally a parasympathetic supply slowing the heart down, which, as I mentioned, it comes from the cardiac branches from the vagus nerve. And that's it. Thank you.
Thank you, Dr. Rawan. Our panelists today, can you lead the discussion, please?
Thank you, Rawan. Well done, yani. Very explanatory and informative lecture. I like the photos that you put. If anyone have any question or comments, and we have Dr. Rasha also with me.
I would like to comment, Amjad. I really like the presentation, Dr. Rawan, and I like the photos with pictures. As Dr. Amjad said, great effort. Thank you, Dr.
Thank you, Dr. Ayat.
Okay, if we don't have any more question, I think she can proceed to the next lecture.
Okay, we'll have a break for 5 minutes, then we'll go with the second lecture, inshallah. Thank you. دكتور روان تفضل you can start.
Okay. So I will start with my second lecture, the anatomy of the great vessels of the heart and the coronary arteries and coronary veins. So the great vessels of the heart are located in the mediastinum. They help to transport blood to and from the heart. There are 5 great vessels which enter and leave the heart: the aorta, the pulmonary arteries, the pulmonary veins, and the superior and inferior vena cava. The aorta is the largest artery in the body that carries oxygenated blood to the rest of the body. It arises from the aortic orifice at the base of the left ventricle, pumps the blood from the left ventricle to the body through the aortic valve. It divides into 4 sections: the ascending aorta, the aortic arch, the descending thoracic aorta, and the abdominal aorta. The aortic root is the portion of the aorta beginning at the aortic annulus and extending to the sinotubular junction. It is sometimes considered as a part of the ascending aorta, and it can be considered as a separate entity from the rest of the ascending aorta. So mainly the ascending aorta begins at the sinotubular junction. It is 5 centimeters long, and it runs through a common pericardial sheath with the pulmonary trunk. At the root of the ascending aorta, we have the aortic sinuses, or the sinus of Valsalva, as I mentioned earlier, which give rise to the coronary arteries. The left aortic sinus contains the origin of the left coronary artery. The right aortic sinus gives rise to the right coronary artery. The posterior or the non-coronary sinus does not give any coronary artery. After that, we have the aortic arch. It loops around the left pulmonary artery and the bifurcation of the pulmonary trunk. It has 3 major branches from proximal to distal: the brachiocephalic trunk, the left common carotid artery, and the left subclavian artery. The brachiocephalic trunk, which further divides into the right subclavian and the right common carotid artery, they supply the right side of the head and neck, as well as the right arm and the chest wall, while the left common carotid artery and the left subclavian together, they supply the left side of the same region. The aortic arch ends and the descending thoracic aorta begins at the level of the intervertebral disc between the 4th and the 5th thoracic vertebra. The thoracic descending aorta give rise to many branches: the superior and inferior left bronchial arteries, and variable branches to the esophagus, to the mediastinum, and to the pericardium. Its lowest pair of branches are the superior phrenic artery, which supply the diaphragm, and the intercostal and subcostal arteries. It leaves the thorax through the aortic hiatus in the diaphragm at the level of T12, where it becomes the abdominal aorta. The abdominal aorta begins at the aortic hiatus at the diaphragm at the level of the 12th vertebra. It is approximately 13 centimeters long. It gives rise to lumbar and musculophrenic arteries, renal and middle suprarenal arteries, and visceral arteries. It ends at the level of L4 vertebra bifurcating into the left and right common iliac arteries. The pulmonary arteries receive a deoxygenated blood from the right ventricle and deliver it to the lung for gas exchange to take place. The arteries begin as the pulmonary trunk, which is a thick and short vessel, separated from the right ventricle by the pulmonary valve. The trunk is located anteriorly and medially to the right atrium, sharing a common layer of pericardium with the ascending aorta. It continues upward, overlapping the root of the aorta and passing posteriorly at around the level of T5, T6. The pulmonary trunk splits into right and left main pulmonary arteries. The left pulmonary artery supplies the blood to the left lung, bifurcating into two branches to supply each lobe of the lung. The right pulmonary artery is a thicker and longer artery, supplying blood to the right lung. The pulmonary veins receive oxygenated blood from the lungs, delivering it to the left side of the heart. There are 4 pulmonary veins with one superior and one inferior for each of the lungs. They enter the pericardium to drain into the superior left atrium on the posterior surface. The oblique pericardial sinus can be found within the pericardium between the left and right vein. So the superior pulmonary vein returns blood from the upper lobes of the lung, with the inferior vein returning blood from the lower lobes of the lung. The superior vena cava receive deoxygenated blood from the upper body, all the structures superior to the diaphragm, excluding the lungs and the heart, and delivering the blood back to the right atrium. It is formed by merging of the brachiocephalic veins, traveling inferiorly through the thoracic region until draining into the superior portion of the right atrium at the level of the third rib. The inferior vena cava receive deoxygenated blood from the lower body, so all the structures are inferior to the diaphragm, delivering it back to the heart. It is initially formed by in the pelvis by the common iliac vein joining together. It travels through the abdomen, collecting blood from the hepatic, from the lumbar, gonadal, renal, and phrenic veins. The inferior vena cava then passes through the diaphragm, entering the pericardium at the level of T8, and it drains into the inferior portion of the right atrium. So the coronary arteries arise from the coronary sinuses immediately superior to the aortic valve and supply the myocardium with oxygenated blood. They run along the coronary sulcus of the myocardium. So there are 2 primary coronary arteries, the right coronary artery and the left main coronary artery. The major coronary artery forms a circle and a loop around the heart. The circle is formed by the right coronary and the left circumflex artery as they course along the atrioventricular groove. The loop is formed by the LAD and the PDA as they encircle the interventricular septum. The right coronary artery courses anteriorly and laterally from its origin at the right coronary ostium, descending into the right atrioventricular groove, and inferiorly toward the acute margin of the right ventricle. It courses around the inferior surface of the heart, and after giving off the PDA, it continues as the posterior lateral artery. The main branches of the RCA includes the sinoatrial nodal artery, which is present in 55% of the patient and 45% coming from the left circumflex artery. The infundibular or the conus branch that courses anteriorly over the right ventricular infundibulum. The acute marginal branch that courses over the acute margin of the right ventricle. The anterior right ventricular branch that supply the anterior free wall of the right ventricle. The AV nodal artery, which is present in 85 to 90% of patients coming from the RCA and 10 to 15% coming from the left circ. The posterior descending artery in 85 to 90% of patients from the RCA and 10 to 15% from the left circ, which runs in the posterior interventricular groove and gives off septal perforator arteries, which branch perpendicular into and supply the posterior 1/3 of the ventricular septum. Finally, the posterolateral artery supplies the posterior surface of the left ventricle. The dominance refers to the artery from which the PDA originate, not the vessel which supplies the greater myocardial muscle mass. So a right dominant system occurs in 80 to 85% of the patient, where the PDA is a terminal branch of the right coronary artery. A left dominant system occurs in 10 to 15% of the patient, where the PDA is a terminal branch of the left circumflex artery, and a co-dominant system where it comes from both, which occurs in approximately 5% of the patients. So the left main artery courses from the left ostium anteriorly and inferiorly to the left, between the pulmonary trunk and the left atrial appendage, until it reaches the left AV groove. Typically, it is 10 to 20 millimeter in length, but it can extend to a length of 40 millimeter. It divides into two major arteries of nearly equal diameter. We have the left anterior descending artery and the left circumflex artery. In some occasions, instead of bifurcating into two, it trifurcates into three vessels: the LAD, the left circ, and the ramus. So the ramus intermedius occurs in around 10 to 30% of the population and is considered a normal variant. It generally goes in the angle between the LAD and the left circ. It may either behave like a large OM or a diagonal branch, and it supplies the lateral free wall of the left ventricle. The LAD, also known as the anterior interventricular artery, it descends along the interventricular groove to the apex of the heart to supply, and sometimes can supply part of the posterior interventricular groove. Part of it may be buried in the muscle. The main branches of the LAD includes the diagonal arteries, which are usually 2 to 6 in number, and course along and supply the anterolateral wall of the left ventricle. We have the septal perforator arteries, usually 3 to 5 in number, which branch perpendicular to the LAD and supply the anterior 2/3 of the ventricular septum. And the right ventricular branch, which supply blood to the anterior surface of the right ventricle, but they are not always present. The LAD is divided into 3 segments: proximal, middle, and distal segment. A proximal third, which runs from the origin of the LAD to the origin of the first septal artery. The middle third, which runs from the first septal artery to the origin of the last diagonal artery. And distal third, which runs from the last diagonal artery to the termination of the LAD. The circumflex artery courses along the left atrioventricular groove and terminate before reaching the posterior interventricular groove. The main branches of the circumflex coronary artery includes the obtuse marginal artery that supply the lateral aspect of the left ventricular wall, including the anterolateral papillary muscle of the mitral valve, the left atrial branches, the SA nodal artery, which, as I mentioned, is present in around 45% of patients from the left circ, the AV nodal artery in 10 to 15% of patients, and the PDA also in 10 to 15% of the patient. The papillary muscle blood supply, have the anterolateral papillary muscle of the right ventricle located near the junction of the apical septum and the free wall, supplied by branches from the LAD. The anterolateral papillary muscle of the LV is supplied primarily by one or more branches from the LAD, but may also can be supplied by the left circumflex marginal branches. The posteromedial papillary muscle of the LV is supplied by terminal branches of the RCA or left circumflex artery, depending on the distribution of these arteries to the inferior surface of the left ventricle. The coronary veins, there is a complex network of veins, drains the coronary circulation. It returns the deoxygenated blood from the myocardium back to the right atrium. We have two systems, the Grade system and the smaller system. In the Grade system, the majority of coronary veins drain to the coronary sinus into the right atrium, which drains the subepicardial myocardium. There are the great cardiac vein, the middle cardiac vein, and the small cardiac vein. Also, there are several larger anterior cardiac vein that drains directly into the right atrium, thereby bypassing the coronary sinus. The small, each coronary vein and the corresponding coronary artery which it runs with. So the coronary sinus, which runs along the left atrioventricular groove in the posterior side of the heart, along with the left circumflex artery. The great cardiac vein, which runs in the anterior interventricular groove into the left atrioventricular groove, along with the LAD and the left circumflex artery. The middle cardiac vein, which runs in the posterior interventricular groove, along with the PDA, and finally the small cardiac vein, which runs along the right atrioventricular groove, along with the right coronary artery and the acute marginal artery. That's it. Thank you.
Thank you again, Rawan. I have one comment, but before that, if anyone have a question or something, you can go ahead at any time. Okay, I'm not sure, Rawan, have you ever, I'm quite sure that you are familiar, and you did a good, mashallah, summary of the chapter of the anatomy and a good review of the chapter, but you did not present anything about the surgical incision, right? I'm not sure, because I shifted from mobile. Yeah, surgical incision.
No, surgical incision, no.
Okay. I think it's an important, you did very well, actually. It's not a minor point, but I think it's important to know about, and I'm sure that, you know, it's important to know about the surgical incision of the skin from surgical point of view. So you are familiar. Can you tell us about the surgical incision that it's available in cardiac surgery? or anyone from the audience. If you don't know, or if you have a few, you can reflect the question. Rawan, did you get my point?
You mean surgical incision at the median sternotomy?
Yes, exactly.
Median sternotomy, we have thoracotomy.
Good.
The clamshell incision.
Yes. Yeah, I think it's quite important why I mentioned that, but because in our practice, as you know, and most of our colleagues know, that the surgical incisions are important, the demarcation, the median sternotomy, that you have to demarcate, especially for us as a resident at the beginning of the years, and to do the incision from the beginning, to know that the median sternotomy from where it begins and end, and to be familiar also with the thoracotomy, especially in the thoracic surgery, the anterolateral thoracotomy and the posterolateral, and what kind of surgeries that we need. Also in the mini sternotomy and minimal invasive, also the G sternotomy or the anterior sternotomy, and each one in which surgery. Also, I would like to add one point about the conduit. Also, it's important to be familiar with the conduits of the cabbages. What kind of conduits that we have? You know that also, Rawan, right?
Yeah, sure.
Yeah. Okay, Dr. Rasha or anyone, if he had any point to add, please.
I have a comment, if you don't mind, Amjad.
Sure, go ahead.
It's related to the graft. It's something I didn't know before, but I learned through my vascular surgery rotation. It was surprising to me when I first learned about it, so I want to share it with you. It's regarding the lima and its relation to peripheral vascular disease. I don't know if Dr. Rasha went through the lima anatomy, but the lima comes out of the subclavian, and then it branches into the musculophrenic and then the superior epigastric. This superior epigastric then anastomoses to the inferior epigastric, which in turn goes back to the external iliac, and then and that's the end of the inferior epigastric. But in situations where a patient have lower limb vascular disease, like if he had a common iliac or lower abdominal aortic stenosis and it's chronic, this patient will be dependent on the lima and the superior epigastric and the inferior epigastric for the lower limb blood supply. So this is something that has to be kept in mind before harvesting the lima for someone with a peripheral vascular disease, which is most of our patients who come with cabbage have already have peripheral vascular disease. I hope I made my point clear.
Yeah, good point, Faisal. Yeah, definitely. Yeah, this is why you need to be familiar with the graft and the conduits and their branches. Also, there is some contraindications in some patients who have radiation also. So you have to, know really better about your patients before, so you can have which conduits or which grafts are suitable for each surgery. Okay, anyone have any additional question or comments for Rawan? Okay, I think we'll have a quick break, Abdul Malik, then we'll go to the last lecture.
Thank you, Amjad. Thank you, Rawan. Okay.
Thank you.
We'll have a 5 minutes break, then we'll go with the last lecture, inshallah.
I think Dr. Jumana, she has something to share and comment.
Dr. Jumana, can you prepare your slide, please?
Can you see the slide?
Yes, you can start.
Okay. So good afternoon, everyone. Good afternoon, everyone. My name is Jumana Shahbaz. I am an R1 cardiac surgery at Prince Sultan Military Medical City in Riyadh. Today we will be talking about the subclavian steer syndrome. Can everyone hear me?
Yes, Jumana, your voice is heard. You can go ahead.
Okay, good. Okay, so the subclavian steer syndrome. We will start with a clinical scenario. This is a case presentation of a 90-year-old woman who has underwent CABG surgery 15 years ago. She was brought to the emergency department from her assisted living facility after developing chest pain, dyspnea, and diaphoresis. Upon arrival, she continued to have chest pain and she exhibited signs of congestive heart failure. Let's say we are on an on-call and then this patient presented. What would you like to order? Anyone can participate.
Yes.
What can we order?
We can see the vital signs of the patient.
Perfect. Okay. After that,
we order ECG, 12 lead ECG.
Nice. Okay. So say, who is this with me?
Tasneem.
Okay. Hi, Tasneem. So you did order an ECG, and this was the ECG. Great. Now, can anyone read the ECG and tell me what are the findings in this ECG?
Okay.
Okay.
So this is a 12 lead ECG. There is a normal rate and rhythm and axis.
Good. Okay.
No, it is not normal rate. It is 150, I think.
So it's a little bit tachycardic. Okay.
Yes. We can see ST elevation.
Nice.
And
Where?
lead دقيقة. AVR V1, V2. And ST depression in lead 1 and 2.
Okay.
And V4, V5, V6.
ST depression. Nice. Perfect, Tasneem.
Yes.
So we have her ECG reveals ST segment depression across the pericardium, as Tasneem said, which is associated with ST elevation in the AVR. What is the interpretation of this ECG? When you see across the pericardium ST depression and AVR ST elevation. Does anyone know?
Is it posterior? Am I? No.
Okay. No, but if you Google it, you can see that ST elevation in AVR with coexistent multi-lead ST depression indicates subendocardial ischemia due to oxygen supply demand mismatch. So it doesn't really tell us where exactly is the ischemia, but you can see it's subendocardial ischemia. Okay, so let's see what happened with this patient. After that, after the ECG, and we saw that she has subendocardial ischemia, what are we going to do? So the patient came, you ordered an ECG, you saw that she is having ST depression and ST elevation, she's having ischemia, she has a history of CABG 15 years ago. What will you do?
Okay, you can order CBC, troponin, ischemic
Okay.
markers, cardiac markers, yes.
Okay, and where will you take the patient?
You'll take the patient right away to the cath lab.
Nice, perfect. So giving this clinical picture, she was urgently taken to the cath lab where the angiography revealed total occluded native arteries. The saphenous vein graft to the right coronary circulation was patent, as was the left internal mammillary artery bypass to the left anterior descending artery. So her native coronaries were occluded, which is expected, but all the grafts we have done before are patent. And until now, we don't know what is the reason for this patient's ischemia and presentation of angina and decompensated heart failure. Now, this our lecture is about one of the reasons that we can face that can give us such a clinical picture. So let's talk about the subclavian seal syndrome. Definition: it's a phenomenon of reverse blood flow. You will have reverse blood flow in a branch of the subclavian artery, which is a result of ipsilateral hemodynamically significant.
Jumana, your voice is out. We cannot hear you. We can see your slide, but I cannot hear any voice. I don't know if there's a problem with me or anyone else also.
I cannot hear her voice also.
Abdul Malik, kindly, if we can notify her or to contact her in any way.
Joanna, maybe it's better to, if you're trying to leave and rejoin, maybe that would help.
Hi.
Yes,
Hello.
we can hear you now. You can share your slide again.
Okay. So where did you lose me?
Before the pathophysiology, at the definition of the subclavian seal syndrome.
Okay, so let's talk about the definition and the pathophysiology. We will have
your slide first, Jumana, sorry. Your slide. We cannot see your slide.
Okay.
No, share the screen, please.
Okay. Can you see the screen?
Yes, before that, the slide before.
Okay, so this is the definition. Okay, so it's a phenomena of reverse blood flow from the branches of the subclavian artery as a result of ipsilateral hemodynamically significant lesion to the proximal subclavian artery. If you can see here, we have a significant lesion in the proximal subclavian. As a result, the pressure post the stenosis is going to be low, and that's gonna make a better pressure gradient for the blood flow to be reversed. It will steal the blood flow from the branches of the subclavian. For example, you can see the vertebral artery here. The blood flow is being reversed or stolen from the vertebral artery and basilar artery back down to the post-stenotic lesion from the subclavian artery. The same thing happen if you have a Lima to LAD graft, if you did a CABG before. So, and then the blood will be stolen from the Lima that is supposed to go to the heart. It will be stolen to the right arm. So it could compromise the distal perfusion to the Lima, as we said, and the vertebral artery or the axillary artery. Is that clear?
Yes, clear, but just try to go a little bit slow in your rhythm and voice, please.
Okay, I will try. Okay, the causes of the subclavian stale artery. As we said, the subclavian stale artery is basically stenosis in the subclavian artery, proximal subclavian artery. What is the most common cause for stenosis in any artery? The most common cause is atherosclerosis. So the most common cause is atherosclerosis. That's in 80% or more of the patients who have subclavian stale syndrome. Other causes could be large artery vasculitis, thoracic outlet syndrome, or any compression syndrome. We can have stenosis in the subclavian after surgical repair of aortic coarctation or tetralogy followed. So here the history of the patient and the previous procedures or operation he has done is very important. Also, you can have some congenital abnormalities such as right-sided aortic arch with an isolated left subclavian artery. This can lead to subclavian narrowing وبالتالي Steele syndrome, and it should be considered, particularly if the Steele syndrome develops at a younger age patient. We think congenital abnormalities. However, if you have subclavian Steele syndrome, the most likely cause and the one you want to look for is atherosclerosis. Okay, let's talk about the risk factors. If we are talking about the risk factors of the subclavian Steele syndrome or subclavian artery stenosis, as we said, atherosclerosis is the most common cause. So what are the risk factors for atherosclerosis? As we know, smoking, whether it's past or current smoking, high level of high blood pressure and cholesterolemia, and PDA. PDA is the single strongest predictor of subclavian artery stenosis, with its presence conferring a 5-fold increased risk of having subclavian artery stenosis. So any patient who presents to us with PDA, low peripheral artery disease, we put that as PAD as which is peripheral artery disease. We can say that this patient has a 5-fold increase in the risk of having subclavian artery stenosis. Okay, clinical presentation of the syndrome. In the majority of patients, the subclavian stenosis with or without blood flow reversal is asymptomatic. So usually the patients have no symptoms. However, patients with the flow reversal can become symptomatic. When do the patients become symptomatic? If there is increased demand on the right arm, مثلا, for example, that will cause blood supply to be stolen from other circulation into the right arm. That will cause subclavian Steele syndrome to be clear or symptomatic. So it will only be symptomatic if the blood supply cannot accommodate increased demand, such as during exercise, or another scenario is the stenting of an AV fistula. For example, if you had a patient, if you did a CABG for a patient with a Lima to LAD graft, and the patient was okay, he went home, and then after years, say he developed end kidney disease, end-stage kidney failure or kidney disease, and you needed to put an AV fistula in the patient, if you put it in the same arm of the graft and the patient had an undiagnosed stenosis in the subclavian artery, then here is going to be increased demand and there will be failure in the circulation, and the patient is going to have symptoms of the subclavian steal syndrome. Am I clear?
Yes.
Yes, clear.
Okay.
Go ahead.
Okay. Those are the symptoms. If we can look at the picture, the symptoms, they don't, usually there are no symptoms, but if there are symptoms, they will depend on where is the stealing from. For example, if you can see, if the stealing or reverse blood flow is coming from the vertebral artery, so then we are compromising the circle of Wills and we are compromising the blood flow to the brain. So the patient will present with dizziness, vertigo, imbalance, drop attacks. He can present with TIAs. They can present with hearing loss or nystagmus. But if the patient had a stealing from the internal mammillary artery, he can have angina, compensated. He can have heart failure, decompensated heart failure, or acute or new onset heart failure. He can also have angina or myocardial infarction. And in the upper extremity, because there is decreased blood flow, patient can have claudication, heaviness in the upper extremity, fatigue, coldness, or even, and he can have exercise-induced symptoms in all of the 3 types of the subclavian steal syndrome. Okay, this is the coronary subclavian steal syndrome is a subtype of the subclavian steal syndrome. As we said, it occurs in patients who have undergone coronary artery bypass graft if the stenosis occurs in the subclavian artery proximal to the takeoff of the IMA graft utilized to perfuse the heart. If the arterial blood demand is increased in another vascular bed, like in the upper arm, مثلا, with an ipsilateral upper arm exercise, a share of the coronary circulation will be stalling, leading to angina and even infarction. The symptoms can vary from angina, acute coronary syndrome, new onset and decompensated heart failure, and patients can have malignant ventricular arrhythmias. Okay, the prevalence, the largest registry to date studying the prevalence of the subclavian artery stenosis, defined as more than 15 millimeter mercury interarm brachial systolic pressure differences. The meaning is, how do you know that this patient has a subclavian artery stenosis? You see the blood pressure difference between both arms, and if there are more than 15 millimeter mercury interarmal difference in the pressure, you say that the patient has subclavian artery stenosis. It is actually found in 2% of the general population and in 7% of a clinical population enriched with patients who are known or suspected to have PAD, peripheral artery disease. As we said, PAD has a very important correlation with SAS. Okay, in patients who have both PAD and coronary artery disease requiring CABG, 11%, 0.8, were found to have proximal left subclavian artery stenosis, which is a high number, almost 12% of patients. However, not all left subclavian artery stenosis results in the coronary subclavian steal syndrome. It has been estimated that coronary subclavian steal syndrome complicates 0.2 to 6.8 of the patients who have undergone CABG with the Lima graft. Even with those numbers, several authors have postulated that this is likely an underestimation of the number, because as the number of the Lima grafts has increased and the life expectancy has improved in general, so this could be an underestimation. What is the significance? What is the significance? The significance is that the presence of the steal syndrome can jeopardize the anterior myocardium, which is supplied by the Lima, which compromise the mortality benefit provided by a Lima graft to the LAD artery. So even if you had a patient and you did a perfect surgery and put your Lima to LAD, and he had an undiagnosed subclavian steal or subclavian artery stenosis, that can jeopardize the myocardium supplied by your conduit. Okay. Diagnosis, as we said, most of the people who are going through the syndrome are have no symptoms, so it's asymptomatic. بالتالي subclavian stenosis should be suspected in any patient with vertebropatellar territory neurological symptoms or arm claudication or coronary ischemia where the IMA has been used for the coronary artery bypass graft. So if we know this piece of information, it would be easier for us to put a differential diagnosis for our case presentation at the beginning of the lecture. Okay, if we want to do the physical examination findings, the physical examinations are going to be different according to which type, where the steel is happening, as we said. So if it's in the vertebropatellar territory, neurological symptoms that we have mentioned before. If it's in the arm claudication, paresthesia, coolness. If it's in the coronary, as we said, angina, malignant arrhythmias, and heart failure. The diagnostic modalities, we used are continuous wave Doppler and duplex ultrasonography. If it's in the brain, we use, if the patient has neurological symptoms and we are suspecting vertebropatellar artery steal syndrome, we can do a transcranial Doppler. We can also use the magnetic resonance angiography and the computed tomography angiography. They are alternatives. However, we are not using them as much in practice because the Doppler and the ultrasonography are very sensitive, and you don't need to use the MRA or the CTA unless you have an unconclusive ultrasonography, then you can use them. Or if you need to plan your intervention, then you can use the MRA or the CTA. However, Doppler is the one to go to. Okay, management. We said most of the patients are asymptomatic, so why do we want to manage them? We're going to have to manage them because the even asymptomatic subclavian artery stenosis is associated with increased risk of morbidity and mortality. Okay, the presence of subclavian stenosis is associated with increased total mortality. The hazard ratio is 1.4, and cardiovascular disease mortality hazard ratio is 1.57. And with an increased risk of the cerebrovascular ischemic events related to progressive carotid stenosis and compromised collateral pathway. This, بالتالي, management, we have to manage it because the subclavian stenosis is a marker of the cardiovascular risk and identifies the population that will benefit from aggressive secondary prevention. We have found that the aggressive secondary prevention that works in the subclavian artery stenosis is similar to the regimen that we use in the patients who have peripheral artery disease. Who can tell me what is the medical management of peripheral artery disease?
Maybe a statin and aspirin.
Okay, nice.
Antiplatelets
Statin.
and statin.
Okay, statin, aspirin, and
lifestyle modification.
okay, great. So we start with lifestyle modification, and then we give aspirin, statin, as he said, and beta blocker and ACE enzyme. Okay, that is the management for the medical therapy. Then we can do revascularization therapy. The revascularization therapy could either be surgically or percutaneously. The point is there is no revascularization therapy in the absence of symptoms. If the patient has no symptoms, we just go with the medical therapy as we mentioned the medical therapy, and that's it. We don't do revascularization, except in one exception. The only exception is among patients whom coronary artery bypass graft with an ipsilateral lima is planned. Here, we need to do preemptive treatment of the subclavian stenosis. Why? Because we know if we did not treat the subclavian stenosis, if we didn't do revascularization and we took the patient to surgery and we did establish to the patient, he's going to have symptoms of the steal syndrome eventually. Okay, the surgical revascularizations, we have various open surgical techniques. We can do carotid subclavian bypass or carotid to carotid bypass, subclavian to subclavian bypass, or subclavian to axillary bypass, and subclavian carotid transposition. There are different surgical techniques. Some of them are superior, some of them are inferior in the outcome and the patency, and we will see this shortly. Okay, the intervention outcome, the technical success of the percutaneous approach can be achieved in 90% of the patients with 5-year patency rate of 85%, which is very high. Okay, how do we see how do we predict which are the patients who would respond better to the revascularization therapy and who are the patients who would respond poorly to the revascularization therapy? This depends on the blood flow reversal. If the patient had before any intervention, he had continuous flow reversal, that we say this patient has a higher risk of restenosis compared with those patients who have intermittent flow reversal at the baseline. Ultimately, whether he has high risk of restenosis, low risk of restenosis, if you do percutaneous approach, up to 10% of the patient will have symptomatic restenosis. And 95% of those 10% can be managed by repeat endovascular therapy. Okay, surgery has patency rates in excess of 70% at 5 years. However, the success rate is 80%, more than 80% if common carotid is used in the bypass. As we said, there are different types of the bypasses. If we use common carotid technique in the bypass, the success rate is more than 80%. In contrast, if we use axillary bypass, that has significantly lower patency rates, which is lower than 50%, 45%. And therefore, it is typically reserved for patients with elevated preoperative risk. Okay, now we said that we can do it per revascularization, percutaneous or surgical. How do we choose between them? Percutaneous endovascular intervention versus surgical revascularization, we can make our decision based on the guidelines. According to the 2011 ESC guidelines, they recommend percutaneous balloon angioplasty with stent support as the first-line treatment for the subclavian artery and brachiocephalic trunk stenosis or occlusion. They said surgical revascularization should only be considered after failed endovascular treatment in low surgical risk patients. However, the 2011 ACCF AHA guidelines endorse both surgical and percutaneous balloon angioplasty with stent support as reasonable first-line choices for the revascularization. Okay, if we are looking for the EBM, the prospective randomized controlled trial comparing the two modalities, which are the percutaneous endovascular technique to the surgical revascularization, have not been published. But if we look for the retrospective study, the largest retrospective study comprised 167 consecutive patients undergoing CABG with the left subclavian artery stenosis or occlusion, demonstrated that the endovascular revascularization with the BES prior to using the LEMA for CABG was safe and effective with a low incidence of peri-procedure complication and instant restenosis. Patency rates were 95%, 39%, 68%, and 75% at 1, 2, and 5, and 10 years respectively in the endovascular arm. So if we would like to do endovascular, the patency rate are very high, which are actually comparable to the preferred subclavian carotid transposition surgical technique of 100, 168, 86, and 68 at 1 year, 3 year, 5 year, and 10 year respectively. So up to here, that is a decision up to the surgeon, and the expertise available. Even the guidelines do not tell us which one is to do or when. Okay, this is the case presentation outcome. As we said, all the grafts that was done in the operation were patent. However, there was a severe 99% left subclavian artery stenosis. What happened is that we stent the left subclavian artery, which resulted in resolution of the patient's chest pain and the echo abnormality. She was discharged home 9 days later. Okay, recommendations. The subclavian artery stenosis screening recommendation in the current coronary artery revascularization guidelines are lacking and need to be included. So if you look in the literature, there are not guidelines for screening of the subclavian artery stenosis before doing CABG, and that should be included. Also, prospective randomized controlled trials, as we said, comparing the percutaneous endovascular technique to the surgical revascularization technique are lacking, and they should be there in the literature. Those are my references, and if anyone has any question, please don't hesitate to ask.
Thank you, Jumana. I really liked your way of presenting that presentation by putting a scenario. It's very professional, and asking question and making it more interactive. So please, if anyone have a question for Jumana or comment, go ahead.
Yes, first I have a comment and a question. Thank you very much, Jumana. Very well prepared, a nice presentation. Very obvious you read the topic in details and you understood it well. So well done. So the comment is about the screening. So I faced this maybe in 2 different occasions. So usually, as you said, the ultrasound carotid, sometimes good radiologists will report back as there is some kind of reversal of flow and suggestive of steel. And that happened with one patient, and that gives you an idea about your strategy in the OR for CABG. This is the first thing. So yeah, sometimes you get it because in our hospital, the Competency Riyadh, we do ultrasound carotid as part of routine
workup. Yes.
Workup, yeah, for every single patient. So yeah, so that might give you an idea if there's significant stenosis. So my question: if such patient, let's say youngish, early 50s, comes for CABG, and you absolutely know that this patient diagnosed him with subclavian stenosis. So what will be your strategy in the OR? Will you use what kind of grafts? Will you use the Lima or not?
Okay, first, if I know beforehand that the patient has the subclavian stenosis, it is recommended to do the endovascular revascularization and then take the patient to the CABG. However, if I didn't know, which I think your question is in the OR, what to do, I think it would be safer not to take the Lima.
Exactly what many surgeons would do. That would do like you mean vein grafts, isn't it?
Yes.
Yeah. Yes. Very good answer. And another way is to solve this issue is to use the Lima as a free graft. If you use the Lima as a free graft, so you take it out from its origin and then you put it on the ascending aorta to the LAD. Actually, free grafts of Lima have very good results, and some surgeons specialized in coronary vascularization report it as good as the non-free, or we call it Lima. So with patency of 90%.
I see. Okay, perfect. Thank you.
Anyone
I have
any?
a question.
Yes, go ahead.
Thank you, Jumana. Your presentation was thorough, and I liked it very much. My question is very basic regarding the mechanism. The way I understand subclavian C syndrome is, let's say the left subclavian has a proximal stenosis. It will start stealing from the vertebral artery and from the Lima.
Perfect. Yes.
The thing that I cannot understand is what drives the blood flow from the Lima into the left subclavian. How come the blood? I can understand how the blood can come from the vertebral artery. I mean, less resistance because of less blood in the subclavian, and it's with gravity. From the Lima, it's coming against gravity, and it overcomes the resistance of the Lima, like the whole vessel. So what drives it exactly? I cannot understand or
Okay,
imagine
perfect. This is a
or
good
even
question.
think of a mechanism of the blood flowing into the subclavian.
I see. Yeah, okay. So this is a good question. The basic thing or the basic mechanism is the pressure gradient. If you have a more pressure in the subclavian, distal to the stenosis, then distal to the stenosis, that normally you have more pressure in the subclavian. So the blood will go through the lima to the heart. But if you have a proximal stenosis in the subclavian, the pressure after the stenosis is going to be low. And if you exercise the upper arm, say you exercise the arm, and then the pressure is going to be even more low, and the demand of the blood is going to be higher in the arm. So that will steal the pressure, the blood from the lima, even against the gravity, as you said, or the other factors, because of the pressure gradient.
Yeah, but I understand this. But where does the high pressure come from in the lima? Because the lima supplies blood to the coronary. So if the lima is not supplying enough blood to the coronary does not have high pressure. Where is the blood coming from? The venous system of the coronary veins, I don't think it's even higher than the subclavian, enough to at least to drive the blood the way I imagine it. You don't have to answer that, Jumana. Maybe someone else can have found an answer.
I understand your question, but I'm not sure where does the blood come from. I think the blood supply in the arm tries to steal as much blood as possible from whatever possible. And that depends on the pressure gradient. That's from what I read. But where does the blood come from exactly? I'm not sure. If someone else who has more knowledge can tell us.
Faisal, again, your question? I didn't get it right.
From higher pressure.
I cannot hear you very well. Can you repeat? I cannot hear
me now. Do you hear me now?
Yes.
Great. What I know that pressure fluids move from high pressure areas or high pressure tubes into lower pressure, or from higher resistance into lower resistance. So when the subclavian has a proximal stenosis, it becomes a lower resistance or lower pressure area, and it starts to steal from the vertebral artery and from other branches. But the thing is, how come the blood from the lima can go against gravity to the subclavian? The only way I can think of it is for the lima to have a higher pressure than what is inside the subclavian. But where is the source of that pressure? That's what I cannot understand, or I cannot think of a source of pressure, because all of the blood supply going to the coronary, to the LAD, is coming from the lima. Now there is no blood supply. And we know that the LAD is, for sure, when we have a lima to LAD, it's stenosed. So it's even a lower pressure area. So how can the subclavian steal blood from the LAD? I cannot understand how that can happen.
As Jumana said, because of increasing the demands of that subclavian, so it will steal and go with the subclavian instead of the coronaries, and that's what in the scenario of Jumana that mentioned that can cause ischemia to the grafts, although it's are patent. I don't know if you get the point. Faisal, your voice is interrupted.
Do you hear me now?
Yes, now we can hear you.
The thing is, I understand how it happens, but I cannot explain it like physiologically how it happens, like in simple physics. Like the way the blood comes from the vertebral artery into the subclavian, you have more blood system because the right subclavian is working, and the blood chooses to go through to the left subclavian because of it's a lower pressure system. But
actually, Faisal, your voice is interrupting, and I don't know if this problem happening with me or anyone else.
No, I think I know the reason. I am speaking to you through the phone.
Yeah,
and
it is interrupted, yeah, Faisal.
Sorry, I think my connection is bad. Anyway, it's a basic question and it's not that important.
It's fine. If you can write it down, or anyone else, if you get the point, please go ahead.
Yeah, can I comment, please? This is Murtada.
Yeah, sure. Go ahead.
Faisal, I just need to understand your question. Is your question where does the retrograde blood flow is coming to the lima and then to the subclavian? Is this your question? Are you asking about the source of the retrograde blood flow?
No, it's not the source of the blood. I'm asking about what is the force driving the blood through the lima into the subclavian.
That was answered already. Is the pressure gradient? But so you said you do not you cannot imagine from where the blood is coming from, and
no.
We know that
that means the force is the pressure gradient. The force is the pressure gradient, right?
But you have your lima anastomose to the LAD, and your voice is interrupting. But basically, you have proximal stenosis, and your lima is anastomose to LAD distal to that stenosis, and you have the retrograde blood flow coming from the LAD through the lima and then to the subclavian by the previously mentioned mechanism. I don't know if you have a deeper question, and I don't understand your question, but if you do, you can just write it in the group and we can discuss it.
Yeah, he's writing. His connection is bad. Otherwise, we can explain it more. But thank you, Murtada, for adding this point. Anyone else has any additional on this point?
Allow me, what I think is the source of pressure gradient is the difference in perfusion between the coronary perfusion and other tissues perfusion. So coronary perfusion is during the diastolic, not systolic, and the flow is still happening systolic. You get my point? So coronary perfusions happen during diastolic. So during systolic, the pressure will be high in the coronaries. Also, retrogradely will be high in the lima, more than other vessels. So the flow will not go easily to the lima. It will go direct to the subclavian.
That is so smart. Yes, I think that's the right answer. Yes.
Yeah, the thing is we are explaining, but hopefully Faisal is getting the answer. Okay, nice discussion. Anyone have any additional question or comments? Dr. Farid Khugair, maybe if he's here, I don't know, or anyone from the seniors. Okay, actually, I would like to thank the organizing committees for such an organization, and also the presenters, and the idea of being a panelist for the future way of learning and organizing the conferences. So thank you all, and I hope it's we answer all the questions and we lead the discussion very well. And hopefully, inshallah, in the future will be much better. Thank you. I'll leave the mic and the floor for Abdul Malik or Muhannad.
Shukran, Amjad. Thank you, Jumana. Good discussion. We had this activity today. So we finish all our lectures for today. We'll go. Dr. Farid, have anything to add or comment, or to go back to our MCQs review?